Thanks. Yes, those results were just presented this past week at the TCT conference. And the results of the study were very positive for TAVR, for transcatheter aortic valve replacement. What we found was that the initial procedures were much more expensive with transcatheter aortic valve replacement by about $19,000 because the price of the TAVR valve is much more expensive. But there were a lot of cost savings that happened downstream. The hospitalizations were much shorter by about 4.5 days. Patients were much less likely to need to go to rehabilitation or to have home health services when they went home. And in the early period after the procedures, they were less likely to be rehospitalized. And so at the end of the initial hospitalization, the costs were very close, very similar between TAVI and surgical aortic valve replacement. And then over the next 24 months, there were another $2,600 worth of cost savings, so that at the end of 2 years, the cost difference was actually about $2,000 less with TAVI than it was with surgical aortic valve replacement. In addition, we found that the patients had better outcomes. There was a little bit, very small, but a meaningful amount of additional survival in the TAVI group. And there was also better early quality of life in the TAVI group. And then we measured that in something called quality adjusted life years, which were about 0.05 greater with TAVI than it was with surgical aortic valve replacement. When we put all of this together, the 2-year cost effectiveness was very favorable with TAVI. It was what we call economically dominant, which means less costly and better outcomes. And that was the case 84% of the time when we reran the trial. And it was cost effective at a threshold, a value threshold of $50,000 per quality adjusted year of life gained, which is considered very high value in the United States. And it was cost effective at that threshold about 95% of the time. So it was very favorable for TAVI, but that's at the 2-year time point. We don't know what's going to happen from 2 years to the rest of their lives, and that obviously is very important. And so we did some additional analyses, and certainly what we see is that as long as the results of TAVI that we've seen so far hold up, that there is no catch-up from surgery, then these results will be sustained out through 10 years and probably through the patient's lifetime. But if there are differences in long-term survival, even very modest differences, that could change the equations, change the calculations, and make surgery the more cost-effective alternative. But we need longer follow-up to answer that question. I think the answer right now is no. There are still roles for both procedures. The surgical aortic valve replacement for the low-risk patients is a very safe, a very effective procedure. And so what we, certainly what I believe is that for patients where the valve anatomy is not ideal for TAVI, those patients probably should still be getting treated with surgical aortic valve replacement, because again, that we don't want to trade a low-risk surgery, very straightforward surgery, for a high-risk, very complex TAVI. And those circumstances include patients with very calcified left ventricular outflow tracts, patients at high risk of coronary obstruction, or patients with bicuspid valves that are very, very bulky. Those are areas where surgery clearly still has a role. And the other area is when surgery needs to be combined with other procedures. So if the patient has very complex coronary disease that is not appropriate for PCI, then surgery with a combined aortic valve replacement and bypass surgery is probably still the best option. So TAVI has come a long way. TAVI is appropriate for many patients at low risk, but not for all. The biggest risk is the one that I mentioned in the last question, which is planning for the future. Many of the low-risk patients that we see are in their 70s and or in their 60s. And those patients are very likely going to outlive their first valve replacement and need another valve replacement. And so anticipating that and planning so that we can safely do another TAVI procedure is very important. So that has to do with, again, assessing the anatomy, knowing what the height of the prosthesis is, again, planning in advance for something that might or might not happen. So I think that still is the area that is one of the very biggest challenges. We call that lifetime management of valve disease, planning for the future. And I think that is a very critical factor when performing TAVI these days.